Good morning and welcome. We'll go ahead and call to order the third meeting of the Interim Joint Committee on Banking and Insurance. At this time, Madam Secretary, would you please call the roll?
Senator Rocky Adams, Senator Alvarado,
Here.
Senator Douglas, Senator Girdler, Senator Howell, Senator McGarvey, Senator Parrott, Senator Schickel, Senator Smith, Senator Storm, Representative Bentley, Representative Fisher,
Here.
Representative Flannery, Representative Frazier Gordon, Representative Gooch, Representative Hatton, Representative Kirk McCormick,
Here.
Representative Koenig, Representative Cole Carney, Representative Lewis,
Here.
Representative Lockett,
Here.
Representative McPherson, Representative Meredith, Representative Pollock, Representative Roberts, Representative Santoro, Representative Smith, Representative Stevenson, Representative Upchurch, Representative Westrom, Co-Chair Carpenter, Co-Chair Rowland.
Present. And for a very large committee, we do have a quorum this morning. So I would ask for approval of the June 2nd, 2022 interim minutes, as well as the August 25th, 2022 minutes. I have a motion and I have a second. All in favor? Aye. And the minutes are approved. Do we have any member who would like to recognize anyone in the room or have any comments this morning before we get started? If not, we'll move right into the agenda. First on the agenda this morning is insurance coverage for fertility preservation services. At the table, we have Representative Patrick Flannery and Miranda Sloan. Please introduce yourselves for the record, and you all may proceed.
Representative Patrick Flannery, 96th District.
Miranda Sloan, Executive Director, Kentucky Society of Clinical Oncology.
Thank you, members of the Interim Banking and Insurance Committee. Proud to say that I am a cancer survivor now, and going through that experience, I wanted to try to do something meaningful to help people that have went through been afflicted with cancer and went through chemotherapy like I did. And this topic has come to my attention. It's a policy initiative that has been advanced in our sister states. It's nothing new to Kentucky. I filed a bill towards the end of last session on this topic, plan to make changes to it when I file it again this upcoming session. But it's an important topic that I think we can do very cheaply to help cancer patients that want to be parents have that opportunity hopefully one day. But it is sperm and egg preservation for cancer patients. I know, sure some of you all have had family members go through this, and your mind is really, wandering when you are approaching your treatment. And I really feel like this is something that we can do to create better health outcomes, to encourage people to start the appropriate treatment when necessary. Really what you don't want to have happen is a patient postpone necessary treatment because they're factoring in other considerations like, I want to have children one day, what can I do to preserve, my sperm or my eggs, or as I've learned, oocyte is another biological term. I know Dr. Alvarado can probably correct me if I'm misusing some of these biological terms. But this is something that we can do to give people the opportunity. I think if you were honest on this committee, the people that do have children would probably say that that's the most important thing in their life. And for you all that are grandparents, you all would want to see your grandchildren to be provided this opportunity. But look forward to starting this conversation. If you all have any questions, I'll do my best to answer them. This does get somewhat complicated when you're dealing with insurance companies and health plans and certain coverage issues, but this is something that I think that we can do that is very cheaply to really be a benefit to cancer patients and give them the opportunity to hopefully have a family of their own one day. At this time, I know I've got Miranda here. She has a PowerPoint slide, and I will let her get into the weeds on what other states have done and this concept.
There we go. Good morning. First off, I would like to thank Representative Flannery for raising awareness on this important issue. I would also like to thank this committee for putting this topic on the agenda. So who needs fertility preservation? 160,000 cancer patients will be diagnosed with cancer this year during their reproductive years. Cancer treatment is both treatment-based, systemic, and multifactorial. Chemotherapy, radiation, and surgery can all cause infertility either directly or indirectly. But cancer patients are not the only ones at risk. Patients suffering from autoimmune diseases, those undergoing surgery like hysterectomies, as well as patients being screened for hereditary diseases. So this is Carly. Carly was diagnosed with cancer at the age of 23. Unfortunately, her insurance did not cover fertility preservation. She was, however, lucky in that her parents were able to support her in egg preservation, which cost $10,000 out of pocket. And that egg preservation allowed her to begin treatment with an unparalleled sense of security. Briefly, we're going to define what is fertility preservation. Iatrogenic infertility is an impairment of fertility by surgery, radiation, chemo, or other medical treatments or interventions affecting reproductive organs or processes. The American Society of Clinical Oncology, ASCO, our state, KISCO is a state affiliate of ASCO. We're going to use this definition. Actions that can help you have a baby after cancer treatment, such as storing sperm or freezing eggs. So I guess the real question is, do patients want fertility preservation? And not all of them do, but many would like to be afforded the option. Patients desire parenthood. Survivors express a desire to have children and place an increased value on parenthood as a result of their experience with cancer. They also prefer biological children compared to third-party reproductive options and adoption. Subsequently, infertility causes distress. It's associated with depression, and survivors report poor quality of life. Professional guidelines from the American Society of Clinical Oncology indicate, as part of education and informed consent before cancer therapy, healthcare providers should address the possibility of infertility with patients treated during their reproductive years and be prepared to discuss possible fertility preservation options and/or to refer all potential patients to appropriate reproductive specialists. Most importantly, this is supposed to be done as early as possible. So what are the costs? The options are varied, as well as the expense. Fertility preservation legislative summary. You can see from this map that 33 states, including DC, have introduced legislation. 11 have enacted and passed fertility preservation coverage. Again, it's quite varied across the country. If anybody has any specific questions, we can discuss it later, but I'm not going to read you this entire spreadsheet. So what are the rationales for coverage? 1, fertility preservation is medically necessary. 2, treatments are standard of care. 3, promotes better medical outcomes. 4, it is low cost and potential cost offsets. And 5, there is an ethical basis for coverage. We're going to dig a little deeper into 3 and 4, just to be sensitive to time. So, promotes better medical outcomes. Fertility preservation coverage helps the patient-provider discussions, which are currently subpar. And a lot of times the conversation goes to what we refer to as a wallet biopsy. Basically, how much can you afford because your insurance is not going to support this? This also improves survivorship. There's reduced depression and distress, as well as regret, and patients report a higher quality of life. Lastly, medical outcomes. Some patients don't follow treatment recommendations because they do worry about infertility, and it helps with better decision making. For example, fertility concerns negatively affected tamoxifen initiation and adherence. Tamoxifen is a drug used in patients diagnosed with breast cancer, and premenopausal women have had concerns that the tamoxifen would impact their ability to have children, and another third said it influenced their treatment options. it also doesn't cost that much in the grand scheme of things. For providers, it's very low, pennies. For patients, it's high, extremely expensive for an individual patient, especially females, to afford fertility preservation. The urgency exacerbates the cost, and the patient's facing additional cost of cancer care. In terms of offsets, there's reduced distress, high cost incurred if less effective treatment leads to more disease, and then really quantifying the value of future lives in parenthood. I will leave you all with Tom's story. He was diagnosed with lymphoma at the age of 26. He had his sperm frozen, did not have any coverage, so he had to pay the upfront cost, which was $750 for his first year of coverage, and then another $300 annually thereafter. Fortunately, Tom was able to afford this, and their family said, welcome to new baby in June. And that is all I have for you. Thank you.
Thank you, and thank you both for your presentation. Representative Flannery, did you request a health impact statement on this during session, or do we know, just for the members, what it might cost?
I don't believe that I did. However, there was a similar bill. My research on this indicates that in 2018, it was Senate Bill 95. It was filed by Senator Kerr. It did pass the Senate 34-3. And based on the documents associated with that bill, it appeared that it was 0 to 4 cents per month as to what the cost would be on this. And that's been confirmed with LRC staff as well as to the accuracy on that. But that's the numbers that I have that would kind of give you at least an indicator of what we're dealing with.
Thank you. We do have a couple of questions for members. The first is Representative Lewis.
Thank you, Representative Flannery, and seeing firsthand what all you went through last year and what people affected by cancer goes through, and to be honest, I hadn't really thought about this side of the issue before. My question pertains to the last slide under Tom W., the Hodgkin's lymphoma. He mentions that the annual cost is about $300 for continual storage. I was just wondering what other states were doing as far as the storage costs and what the term of storage typically looks like.
I don't want to tell you something incorrect, so let me get into that, and I will email you if that's appropriate.
That'd be great. Thank you.
Yeah.
And I will say that the storage cost there is a difference between, I guess, the method of whether there's a harvesting of the egg or, can be a difference on, I guess, how that, sample can be given. But the storage cost, from my understanding, and I don't want to really be quoted on this, but I think $300 to $600 is kind of a range that could typically be expected, but that probably could differ depending on whether it's a sperm or egg or what type of methodology was used to extract that.
I understand. Thank you. Thank you, Mr. Chairman.
Thank you. Senator Alvarado.
Thank you, Mr. Chairman, and thank you all. This is important. And I know, like you had mentioned, Representative Flannery, we had looked at this in the Senate and gotten it through at one point. And the big question I've got really is, it has to do with really what Representative Lewis just talked about, was the storage. So let's say if someone has that, and just out of a curiosity for me as to how, I'm sorry I'm around the pole here, as to how what occurs. So if it gets stored and someone stops paying the annual fee, is it just discarded like medical waste? Is it preserved? Does someone maintain ownership of this? That's always a question. Whenever we've had bills that requires anything that might have DNA of any sort, it's always been a discussion. I know in the Senate has always been about, what happens to that material later, who owns it, who disposes of it, et cetera. So maybe if you could speak to that as to what occurs once that's donated. If somebody doesn't maintain for storage, is it just discarded? If someone passes away, is that passed down to the spouse, ownership of that material, et cetera?
Miranda, I'm going to punt to you on that.
Thank you, Senator Alvarado. That's an excellent question. Let me do a little research, and I'll ask and get back with you.
Great, thank you.
I will say this, Senator Alvarado. I think one thing that's going to be important in really dealing with this is, cancer can afflict people at different ages. And so if you have someone, like some of the slides here, you had kind of early 20s, maybe they're not maybe they're not married, maybe they're not. It's not really the time for them to have children, compared to someone that may be, in their late 30s, recently married, and they don't have children. So I think it's important. We're going to have to really try to find the right duration, dealing with the age, and really what their situation is. You can also have a patient in their late teens that, marriage may be, decade away or longer, and how long are we going to have to cover that before that person is ready for parenthood?
One more question, Mr. Chairman, if I could. Is there a cutoff? I mean, I don't know if the medical associations and the recommendations they have, is there a particular cutoff that they have for age? Is it just a matter of if they're still fertile and still willing? So if there might be, let's say, I think of a woman maybe in their early 40s who are still able, but maybe have a cancer and saying, well, I'd like to do this as a preservation because I might want to do something in the future or have a surrogate or whatever, the different situations. Is there a recommended cutoff? Or do the medical associations speak to that, or is it just still open-ended in a lot of states?
Isn't there a federal provision about that, age discrimination?
I can't fully answer that, but I will say, talking to the bill drafter and LRC staff, there are some, I guess, hurdles dealing with some of that, dealing with, ageism, discrimination, and certain factors. So I think that's, your question is something that is going to have to be, dealt with, and those are going to be it's going to have to be addressed.
Great. Thank you, Mr. Chairman.
Thank you. We have one more question from Representative Kirk McCormick.
Representative, thank you very much for bringing awareness to this issue. I commend you on bringing this forward. I come from an area where we have a 30% higher cancer rate than the national average. And for anyone that knows much about cancer, we're seeing it in a much, much younger age group. And I don't know that any of us can escape it in this life. But it's an excellent idea. The preservation of this DNA or the eggs, the sperm, etc. One thing I would like for you in your bill, if it can be done, is to include the cost of the storage. And it's we deal with a lot of people who don't have insurance, and those are people who are with insurance that can afford to do it, is usually the working class, the upper middle class. So this is an excellent plan, and I hope you see it through. Thank you.
Thank you.
Any other questions this morning for our presenters on this topic? Representative Tom Odell Smith.
Representative Flannery, can you kind of clear something up in my mind, because it'll probably be January before we start dealing with this again. Are we talking about already diagnosed or pre-diagnosed on doing this, doing this process? When you find out you have cancer, is this then you start looking for doing this, or can you kind of clarify when this would take place? Or
Well, I mean, ideally, it's pre-treatment. You want to do the preservation prior to chemotherapy or radiation, because that is the treatment is what can impact your fertility. So really, we're dealing with someone that has been diagnosed with cancer. We've got a diagnosis, but they have not started their treatment yet, and that window can be very brief.
Right.
I mean, typically I would think that you've probably got anywhere between maybe a week or two, and then maybe like a month, depending on what type of cancer and what type of treatment is appropriate. I mean, really depending on what type of cancer you have will dictate the treatment. I mean, not all chemo and radiation is really the same. So, but it's all pre-treatment.
Okay, follow up, Mr. Chairman. So we're saying that we're looking at asking insurance coverage to take it on once the diagnosis has been given, but prior to any chemo or anything that could affect the reproduction.
That is part of it, and then after you have that preservation, there's a affiliated storage cost with preserving that, for, X amount of years down the road, depending upon what is appropriate for the patient and really what is a biological reality for that person. So, and a lot of it would depend on the age of the patient and other factors that, have to be considered.
Okay, thank you, Mr. Chairman.
Thank you. And a final question this morning from Senator Rocky Adams.
Thank you, Mr. Chairman, and I really appreciate y'all bringing this bill. I actually had a niece who passed away from breast cancer, and so but she was a Georgia resident, and insurance covered it in Georgia for her to harvest her eggs before her chemo happened. And how and I don't know if this helps Dr. Alvarado, but how they did it in Georgia is clearly the possession went to her husband after she passed. But if there was no activity in a certain period of time, those eggs were immediately, they were transferred to the reproductive clinic there as a donation. And so I don't know if that's something that we might want to look into, that rather than, if there's no activity on that, then they are donated to a reproductive facility. Thank you, Mr. Chairman.
Thank you. And thank you all for being here this morning and for bringing this topic to the committee's attention. And we're glad to have you cancer-free, Representative Flannery.
Thank you. Appreciate it.
Thank you. The next item on the agenda this morning will be a discussion of the Federal No Surprises Act. Our first set of presenters this morning will be Tom Stevens, the Executive Director of the Kentucky Association of Health Plans, and I think Rusty Kress will join him at the table also. And of course, bring anybody else that you have with you that's part of the presentation. Thank you, gentlemen, for being here. When you're ready, if you would, just introduce yourselves for the record, and you may proceed with your presentation.
Thank you, Mr. Chairman. Members of the committee, my name is Tom Stevens. I'm the Executive Director of the Kentucky Association of Health Plans.
And I am Rusty Kress with Dinsmore and Scholl here on behalf of America's Health Insurance Plans.
So we're here this morning to speak about the No Surprises Act. The No Surprises Act is a component of the 2020 Consolidated Appropriations Act. The CAA, as it's known, is one of the most significant mandates on the commercial market since the Affordable Care Act was passed, and may in fact be the largest piece of legislation ever passed by Congress. It's required massive implementation efforts on the part of regulators in a short time frame, and has resulted in health plans and issuers needing to make their best efforts to comply without necessarily having final regulations in place. So at its most basic level, the No Surprise Act prohibits out-of-network providers from balance billing commercial insurance members. Balance billing, sometimes called surprise billing, is a medical bill from a healthcare provider billing a patient for the difference between the total cost of services being charged and the amount the insurance pays.
Now, this topic is certainly, and no pun intended, no surprise to Dr. Alvarado. We've worked long and hard over this issue for many years, and the answer has always been we need to let the feds deal with it, because we don't need patchwork systems throughout the various states. The AHIP supported the No Surprises Act primarily because it keeps a good check and balance situation on balance billing, which end up going toward the bottom line of the consumer, and kind of keeps the two commercial entities out of it. I doubt that there's anyone in the room that could say they have never been balance billed, and it is a shocker. when you see some of these numbers. The keeping the cost low and off the consumer's back is the primary focus for AHIP, and we'll talk a little bit more about that later. But before the No Surprises Act, 1 in 5 patients admitted on an inpatient basis received a balanced bill. In addition, if you go to went to an ER, 1 in 6 patients received a balanced bill. Now, a balanced bill obviously is something that a service or a good that has been provided by a non-participating provider and is not in the network coverage. So the whole purpose, and Tom's going to go through in painstaking detail the history and where we go from here.
Thanks, Rusty. So the chart that I have in front of you now is a timeline of implementation related to the No Surprise Act and the transparency and coverage rules. So you can see dating back to 2020, and where we find ourselves in this gap right now, where there's still a number of regulations that are being implemented and other timeline requirements that have to be hit. So some of the basic protections of the No Surprise Act prohibits surprise bills for most emergency services, even if prior authorization could not be met or emergency resources were out of network. It prohibits out-of-network cost sharing, out-of-network coinsurance or copayments for most emergency and some non-emergency services. Consumers cannot be charged more than in-network cost-sharing amounts for these services, and of course this went into effect January 1st of this year. So the out-of-network cost for an authorized facility, this bans out-of-network charges and balance bills for certain additional services. An example of that would be lab work furnished by out-of-network providers as part of a patient's visit to an in-network hospital or other facility. There's significant patient education requirements. So this requires healthcare facilities to furnish patients with a plain language notice explaining the applicable billing protections, who to contact if they have concerns that a provider or facility has violated the protections, and that the patient's consent is required to waive billing protections. So you must receive that notice and consent to being billed by an out-of-network provider. So individuals specifically covered, group health plans, individual health insurance issuers, carriers under the Federal Employees Health Benefits Program, healthcare providers, facilities, and of course air ambulance services, which we'll talk about more later in the presentation. The NSA specifically doesn't apply to Medicare, Medicaid, the IHS, and TRICARE because that's specifically banned as a matter of federal law, so those already were covered. So specific services subject to the prohibition, non-emergency services are covered if they're provided by out-of-network providers at certain in-network facilities, specifically hospitals, outpatient departments, and critical access hospitals and ambulatory surgical centers. Emergency services and related post-stabilization services are covered if the emergency services with respect to an emergency medical condition are out of network and provided at a hospital or a freestanding emergency department. And there's lots of additional detail and stuff that we can go into in the minutia, but I think I'll probably pass on some of this and keep moving and just subject to your questions. So an important component to this is something called the qualifying payment amount. And this is a measure of locally negotiated market rates defined as the median of all contracts with participating providers in that geographic region for the same or similar item or service. Consumers' cost sharing is determined based on what the terms of in-network cost sharing are for the plan in which they're enrolled. And under the laws and regulations, the determination of in-network cost sharing will be based on either the recognized amount as set by state law or for plans governed solely by the No Surprises Act, the QPA. Keep going. So Another element of this is the independent dispute resolution process, which you'll hear more about. But basically, this is where a health insurance provider or health plan receives a claim of an out-of-network provider attempting to issue a payment or denial of payment to the out-of-network provider. The initial payment can end the dispute entirely, or a provider or facility believes they are entitled to a higher payment amount may elect to begin an open negotiation process. Effectively, this is binding arbitration. So after 30 days of open negotiation between the plan and the provider or facility, if a mutually agreeable reimbursement amount isn't determined, the party can elect to pursue independent dispute resolution. And then it goes into, there's a lot of details here, but I'll skip these and let you go, Russ.
Well, the independent dispute resolution has always been a sticking point as to whether you're arbitrating, whether you're following a less intensive process. And I think from an overall standpoint, nobody is looking for arbitration. In fact, the state of New York implemented a baseball-style arbitration system, and I believe the result was a 300% increase in the price of emergency service claims through that type of arbitration. This independent dispute resolution under the No Surprises Act seems to be a bit more fair, and it should be used sparingly as a backstop in unique circumstances, but it is a key component of the Act.
So factors that go into the QPA, median in-network rate for similar services in the geographic area subject to the CPI, demonstrations of good faith efforts or the lack thereof to reach an agreement on any contracted rates between the parties during the previous 4 years, market share of the parties, patient acuity, and the level of training, experience, and quality of the clinician, or the teaching status, case mix, and scope of services offered by the facility.
One thing that I should add from AHIP's perspective is that a study was released, or a survey recently, that in the first 2 months of 2022, the Act's IDR provisions prevented more than 2 million potential surprise medical bills across all commercially insured patients. So.
Thanks. So this chart tries to lay out some of how this actually flows. Some comments here as far as the scope of service. Emergency services, specifically air ambulance, are included, although notably ground ambulance coverage is not. Non-emergency services at in-network facilities. In-network facilities in scope include a hospital, outpatient department, critical access hospital, ambulatory surgical centers, and freestanding emergency departments separate and distinct from hospitals. And then more on air ambulance. So this is a flow chart of the independent dispute resolution process, determinations, written decisions, and then the payments amongst the parties. Another aspect of the CAA and really the No Surprises Act is the provider directories insurance ID card changes. So provider directories, right now we're in this era of good faith compliance because the rules haven't been promulgated at the federal level. But so it would require updated online directories, verification every 90 days of non-responsive providers, and updated business notifications. Providers are to be included in the directory with name, address, specialty, and additional contact information. And they have to ensure that members who receive inaccurate information that a provider is is in-network, can only be liable for the in-network cost-sharing component. Insurance ID cards are supposed to include in and out-of-network deductibles and out-of-pocket maximum limitations, and also contact information. Also, advanced explanations of benefits as another delayed rulemaking area. This would require plans to provide the following information for scheduled services upon receipt of a provider's good faith estimate: network status of the provider facility, contracted rate for the item or service, or if the provider or facility is not a participating provider facility, a description of how the individual can obtain information on providers and facilities. The good faith estimates from the providers have to show the amount the plan or coverage is responsible for paying, the amount of any cost sharing, and progress towards deductibles and out-of-pocket maximums, and other disclaimers. So there's a number of other requirements that are tangential to this that are involved with prescriptions. I think as far as time-wise, though, I'll just provide that information here, and if there are additional questions, we can respond to it. Again, this information is all delayed and isn't implemented yet. A lot of additional information in the format in which the data will actually have to be provided. The information contained here in your materials is a checklist of provided by AHIP on implementation of the No Surprises Act and its additional regulatory compliance elements provided by AHIP, and is a nice reference tool. So specifically, a little discussion on air ambulance. So, of course, we're all aware air ambulances are typically used to transport patients from the scene of an injury or accident, hospitals, or inter-hospital transfers, particularly in critical situation when time is urgent or when patients cannot safely travel by ground. The number of air ambulance transports, while relatively low, has increased. And so there is concern that we're seeing a shift toward for-profit entities. So notably, patients typically do not have a choice in air ambulance providers, potentially leading to larger out-of-pocket costs for privately insured or uninsured patients. Air ambulance providers are not allowed to send balance bills pursuant to the No Surprises Act. When an out-of-network provider bills an individual for the difference between the billed charge and the amount paid by their plan or insurance, the NSA extends the same protections to private, effective, that was retroactive to January 1st. So as you would expect with a piece of legislation that's this large and encompassing, there's a great deal of litigation that's taking place right now as we go through the implementation process. We were able to identify 8 different cases of some prominence raised by all different manner of interest holders in the healthcare system. Notably, there is one case out of the Eastern District of Kentucky that's pending right now as well. So this is something we'll hear a lot about as we move forward over the next few years. And with that, Mr. Chairman, subject to your questions, I'm sure we'll have a few, sir.
Thank you all. Thank you for the very detailed explanation of the No Surprises Act, specifically to air ambulances. You know, the air ambulance issue, I think, was settled in Kentucky prior to the passage of this, when the carriers and the major providers agreed to go in network on their own, and I appreciate all the work that went around that. Are you all hearing, I'm not hearing of any issues in Kentucky now related to air ambulance, but are you hearing that this is helping countrywide with states that hadn't settled on that issue, or is it having the opposite effect? Are you hearing of any, what are you hearing about that?
It's my understanding that it's helping, but you also have private equity firms that are trying to get involved with the ownership of the provider, and it makes it a bit cross-purposed in terms of providing care versus profit. So,
Got you. Thank you. Sounds like it's maybe something just needs to be watched. See how it goes.
Of the litigation that's pending, Mr. Chairman, a number of those actions have been brought by air ambulance related entities. So you have PHI Health, the Association of Air Medical Services, LifeNet. So you have cases out of Kentucky, Texas, and the DC circuit that are all pending related to air ambulance implementation.
Thank you. Right. Before I turn the meeting over to Senator Alvarado, I'm going to let Representative Bentley ask a question.
Thank you, Mr. Chairman. You know, rest of this probably goes to you. You can go to Europe and charge something on your visa, and that bill will beat you home. Right? Right? Will you agree with that?
I've never been to Europe, sir. I don't know.
Okay,
I assume it
take
will.
my word for it. So you can go to Europe, or you can go to Africa, you can go to Egypt and use your credit card, and that bill will beat you home. Unlike our insurance that's not been worked out in 2 years here in Frankfurt. But the point is, on your insurance cards, and you guys brought it up, why don't you standardize insurance cards in the insurance field? Because everybody has their own group, you know, every plan number. If they were the same place on every card across the United States, it would save you all kinds of man hours and money. Thank you, Mr. Chairman.
Thank you. Senator Alvarado, we do have Commissioner Clark that is going to present. Do you want questions now or wait till after her presentation, or both?
I don't have that much, as much as I think, actually. So, so Rusty, Tom, thank you guys for being here, and thanks for the presentation. This looks pretty familiar. The way this worked out on the federal government, we worked on this bill for at least 2.5 years in meetings, and I was frankly surprised when the feds came up with a solution, because every year they talked about it and it would blow up. Each side would, providers and insurance companies would fight on this, and I just didn't have any faith that they would get it done. So the fact that they got it done was impressive, and really looks very, very familiar to what we were proposing here in Kentucky. It's not identical, but it's pretty darn close. So I was really pleased to see that. A couple of things I just want to mention. When we talk about the definition of what balance billing is, and it's the difference between the total cost of services being charged and the amount the insurance pays, I think it's important for everyone to know that typically the amount that the insurance pays is zero. That's typically the situation when this occurs, is you have a provider that's out of network, and the insurance company says, you're out of network, it's not our responsibility, we're not going to pay. So this solves a problem in which people are stuck with the entire charged amount because the insurance company was unwilling to pay. That's where a lot of this stemmed from, and from a lot of providers that I've talked to, that's important to know. And it's not that the insurance saying, well, we're willing to pay you, $100 for a charge of $200 and negotiate the difference, and the provider says, I'll charge you the extra $100. That isn't what typically occurs. What typically occurred with this was, here's my bill for $200. I don't know who you are. I'm paying you $0. Patient, you figure it out. And that's where they got stuck with this situation. So I think we have to make that very, very clear. The second thing, I know we talked about how many people have been having problems with this. I mean, during the discussions we'd had for those 2.5 years, there were several members of the insurance lobby and others who said, this is not a problem in Kentucky. We don't have this. It's not really a concern. It's not a major issue. And I think your statistics clearly showed that it is. So I'm glad that this got accomplished and got done. I'm happy to see the dispute resolution portion of this, because I think it really helps a lot of folks in that. The baseball style, I think that you had talked about in New York, what they did there was, and we had discussed doing that. And I think both sides didn't like it, because I think it was basically, this is what I want to get paid. This is what the insurance company is willing to get paid. And you had an umpire who said, I'll go with the one that I think is the closest to what they should get paid. And there was no negotiation in the middle. When we talked about it, I think both providers and insurance companies said, we don't like that. We want to be able to negotiate it ourselves. Don't get in the middle of having it go one way or the other. And it seems like in New York, they're siding more with providers, because that's why the reason that the cost would go up with a lot of that. So that is all. I'm glad to see this got passed. I know there's some requirements in this bill also for transparency, is my understanding, to require hospitals and others to start posting what their charges are. There's some discussions we're having now in another bill to try to open that up, to make, because I think it's sometimes difficult to find out what those charges are for transparency, so that consumers don't often know exactly what the charge is. Some of that's being reported. I think it's in methods that are very difficult to find online and very difficult to decipher based on how it's being reported. So we're trying to work on a lot of that. But anyway, that's the biggest takeaways I got. And really, and like I said, a lot of this looked very familiar to what we were looking to do in Kentucky. So I'm just pleased that it got done, and it makes it a consensus across the board, gentlemen. So thank you for coming and presenting today. I appreciate it.
Thank you, Senator. I don't see any more questions for you guys at this time, but potentially we could ask you to come back for questions after Commissioner Clark gives her presentation. But thank you all for being here.
Thank you, Mr.
Thank you, Mr. Chairman.
Members of the Committee.
Commissioner Clark, it's always good to have you with us. Thank you for being
Mr.
here this
Chairman.
morning. When you're ready, please just introduce yourself and proceed with your presentation.
Well, good morning, Mr. Chair and members of the committee. I'm Sharon Clark, Commissioner at the Kentucky Department of Insurance. I really don't have a lot to present today. You got a good understanding of the background of this bill. But I will tell you, 15 years that I've been with the Department of Insurance, I think this is one of the most significant bills. I agree with you, Senator Alvarado, to help Kentuckians. And yes, we have had problems in the past. I can relate one to you where an elderly lady hip came out of socket. The local EMTs decided that instead of using a ground ambulance, they want to use air ambulance, and she got a $39,000 bill afterwards and called the Department of Insurance to try to find out how we could help her. And there was nothing we could do. And that's always difficult for us at the department when we're faced with consumers that are in hardship and we can't help them. The other issue where this comes up so frequently is when that policyholder does due diligence. They find out that their hospital is in network. They found out their surgeon is in network. And then it turns out the anesthesiologist is not in network. And that patient could not choose the anesthesiologist, nor could they choose the pathologist that is maybe looking at that sample, nor can they choose the radiologist. And those are the frequent instances, and yes, it has been an issue in Kentucky. So I'm very happy that this bill's been passed on the federal level. I was asked to talk about our responsibilities with the enforcement of this. And when the bill was passed, we were contacted at the Department of Insurance with a pretty extensive survey question asking for statutory and regulation sites where we could have the authority to enforce this act over the health insurers. So the department completed that. At the same time, CMS was asking, what is your ability to enforce this over healthcare providers? I don't have that ability. That's not in our statutes. That's not in our regulations. And I think the CMS then followed up with other licensing entities here in Kentucky, Board of Professional Licensing, different ones. Again, they did not have that enforcement capability. So when the state is not able to enforce this bill, the federal government will enforce that. So going forward, I have the capability through the department to enforce certain provisions, consumer complaints or whatever, against the health insurers, and the federal government will do it if there are issues with the healthcare providers. As you know, it's requiring the in-network cost sharing, and we, as they mentioned in the earlier presentation, there's transparency requirements, there's ID requirements, and anything that has to do with the health insurers, that falls under our bailiwick, and we'll be there to do it just like we do every day as it is. So, promised you short and sweet, Mr. Chairman, but again, I will emphasize this is a new law, and you heard Mr. Stevens refer to rules. Well, rules are the equivalent, on a federal level, are the equivalent of state administrative regulations on, our local level. So a lot of these rules have been interim, and they're still being developed, and it's new law. Don't have hardly any data at all. You asked the question earlier. I know that the air ambulance issue has been a significant one in North Dakota. Has always been out there leading the charge, and I think it's because of just the small population and how it's spread across the state. But I just don't have the data yet. We have not received any complaints, but we're prepared when we do.
Thank you, Commissioner, for being here. Always appreciate you doing that. I do have a question from Representative Meredith.
Really more of a comment, Mr. Chairman, if I might, and I appreciate that. And Commissioner, I really appreciate you bringing up the idea of what I would consider kind of non-direct services or additional services as a part of medical planning and things of that, and not really an insurance issue. I work in a bank. I check people's credit every day for a living, and one of the things that I hear from them many times is I pull their credit, there's a medical collection on their credit report. Never received a bill for that. And you always wonder, sometimes maybe they're right, sometimes they missed it. Could be a lot of different things. But my surprise came this year when I received a letter from a collection agency on myself fairly recently. And what had happened was I had a chest x-ray back last year. They thought I had pneumonia. And the radiology company who read the bill or read the x-ray had turned me over to collection. I'd never heard of that company, didn't know anything about them. In fact, I had to do quite a bit of checking through a bunch of different avenues to figure out what might have even related to. What I found out was that company just didn't have my insurance information. They didn't try to go to my doctor and get a address or a phone number for me and try to reach out to me. And they just turned it over to collections without trying to do any due diligence to try to do anything to even turn that into my insurance. And so now we're a year after the fact, turning in a bill to my insurance on something that happened a year ago and trying to mitigate that process because these non-integrated services are not working with the primary provider to get somebody billed properly. And I know that's not technically an insurance issue, but from the healthcare provider side and the insurance side, we need to figure out some way to better integrate those spin-off services, I guess you'd say, that as a healthcare consumer, I'm having no direct relationship with. That's a relationship that the provider, who's my direct provider, has with somebody else. And then eventually my insurance will have something with them too. And again, I'm able to mitigate and go through that pretty well because I get something like that, I know where to go. But how many people wouldn't know or have any idea where to go? And when I finally got the research on it, it was truly, they didn't have an address for me, they didn't have a phone number for me, they didn't have my insurance card, so just turn him over to collection. That's not the kind of process that we need in medical billing.
So it was a surprise bill. You're right. And in an instance like that, it certainly would have to be the Attorney General because we would not have any authority. But you're mirroring comments, and I would be surprised if you didn't have multiple people that might have those medical charges on their credit history, and it's due to instances such as this. Thank you, Representative Meredith.
Senator Alvarado.
Just really quickly, Mr. Chairman, just on that Representative Meredith's comments, I mean, I think a lot of what you're seeing now is the corporate institution that healthcare has become. It used to not be that way. I think many of us here are old enough to know, remember when we could go see a doc, the doc would do his own billing, they were independent, those days are long gone. And a lot of that is because we've driven providers into corporate structures, into larger groups, so that you don't have an independent radiologist wanting to do that x-ray. They can't survive often with insurance costs of their own for malpractice, for EMR requirements, all the things that have come down from government and from insurance companies on requirements. It makes it tougher for independent doctors to survive. So a lot of physicians now are driven into larger, massive groups. You have very few independent doctors remaining. I've got an old partner who's called me up recently saying, "Hey man, I'm done with my employer. Let's go open up a practice." Are you kidding me? I mean, there's no way you can survive. You can't just open up a shingle, hang up a shingle, and provide the care that you used to have because of all the requirements, like EMR and lots of things involved. The one thing, Commissioner, I wanted to ask you really quickly. We heard the last presentation there about how some of these providers, they're for profit and they're doing this for money. And there's been a lot of undertones at times, at least my discussions the years that I've been here, that, it's just those providers. They're all money greedy and they're wanting to make money. Do we have any nonprofit insurance companies for healthcare insurance in this state that you're aware of?
No, sir.
No, none. They're all for profit, correct? And often if I'd invite you, if we're going to be worried about profitability, it's not something I've been saying a lot of publicly, but at times I have, of taking a look at the top 10 companies in this country in profitability. I can assure you it's not an air ambulance. It's not a medical practice somewhere in the state. It's not a big radiology group. You can all do that research yourself and see where some of those top 100 or top 10 companies often in this country are. So I think it's very important that we take a look that there's a lot of people that are doing things to create a livelihood. I think the bill that's been passed, I think strikes a good balance in that it brings everybody to the table and forces them to the table to have that discussion and holds the patient harmless, which is ultimately what needs to happen here, is to keep patients out of the middle of this so that the two big groups that are, trying to, again, create a living for themselves, for their shareholders, can find a way to get negotiations done. So, Commissioner, looking forward to seeing how this goes. And if you hear of anything or issues that we need to, as a state, to make our federal representation aware of moving forward, I'd appreciate to know that, because I think, again, what they passed, I was surprised that it got passed. I just didn't think it would happen on the federal level, but pleased that it did, and looking forward to see how that works, and hopefully keeps a lot of people out of harm's way in that regard. Thank you.
Well, Senator, miracles do still sometimes happen, I do want to make one statement, though. This is applicable to air ambulance, but it is not applicable to ground ambulance. So that's one statement I want to make. I would have liked to have seen that inclusion as well, but.
Thank you, Commissioner. The final question, I believe, this morning will be from Representative Fraser Gordon.
Thank you, Commissioner. It's always nice for you to be here. So speaking of air ambulance, so with the implementation of the No Surprises Act, where a patient cannot be balanced billed, is there a need for air ambulance subscriptions anymore? Because it seems if the patient isn't going to get a bill, that they don't need to buy subscription insurance anymore.
Well, really, we don't have any data in yet, but personally, I would not see the need.
Okay, I just want to make sure I was processing and thinking the right way. Thank you.
Representative Odell Smith.
On a follow-up on that, is there very many people that's forced into subscription? Are you getting any phone calls complaining because they're being threatened, or they have to have a service? Or my understanding is voluntary if you want to join.
That's my understanding as
well,
well,
is that free?
Representative Smith, but
Yeah.
it would not come to the Department of Insurance. That would come to the Attorney General.
Well, so they wouldn't complain to the Department of Insurance if somebody was trying to sell them insurance or forcing them to?
Well, the air ambulance service, that is not an insurance policy.
Subscription.
That was a subscription. Yes,
Okay.
that would not come under our
And
auspices.
following up with Representative Merida, I don't know very many people that's not been through medical that doesn't have problems with bills. I mean, I've experienced it, and I know everybody has that's had any kind of medical treatment. But this law that you're talking about is actually new to me, so I'm going to look into how I can have a little bit of leverage when they call. But one thing that I started doing on my provider is I'm going now, and when I sit down with a provider, I'm telling them if they don't give me all my bills, then I'm not paying anything else. So I make my provider know up front that whatever services I'm getting, that I want to know that I'm going to be receiving all the bills, to know what I'm paying. So when I'm done, I know I'm done, and I'm like Representative Merida a year later receiving a notice. So it is, I'm hoping that the senator's right, that this is a solution, because it has been, it's brought up frequently to me on people receiving bills, and after a year or two, you don't even realize, or you can't remember what was taking place sometimes. So I appreciate your testimony today, saying that you feel like this is a remedy, and you feel like it's going in the right direction. But on the air ambulance side, I have a local, and I wanted to make sure that it was understood that that is a voluntary service, that you subscribe to that. So if nobody subscribed, it'd take care of itself. So I don't see any issue on that side of it. Thank you.
Thank you again, Commissioner, for being here. I think you're back again with us next month. Our next meeting date will be October the 18th at 10 a.m. right here. Potentially could be our last one of the interim. So look forward to you all being here. Appreciate the Banking and Insurance Committee staff. They always do a great job of getting these meetings together. And a reminder to the members on the committee that the Insurance Institute of Kentucky is hosting a dinner tonight for us, just for the members of this committee. That's at 7 p.m. in downtown Lexington. So, any other members have anything that needs to come before the committee? If not, I would move we are adjourned.